So next 30 to 45 minutes, what I'm going to do, what is essential for you and I'm going to teach. I'm not going to teach what I know for me. I need to teach you there. And most important, this is my disclosure there. The specialty, if you look at it, where's the specialty I belongs to, this is the specialty I belongs to. I'm least earning specialty compared to all other specialists in my field. Infectious disease won't make money. Infectious disease won't make money. Okay, so people who creating a troubles, people who putting a lot of troubles to us. For example, orthopedic surgeon putting a lot of implants inside. I know here a lot of people put implants also. So you people make money, but we don't make money there because we are trying to solve the problem. We try to solve the problem. So people solving the problem, they are not making money. People who are creating the problems, they are making money. That's a sad paradoxes. And the disclaimer is you can't solve all the problems there. You need to live with certain problems there. You can't say, I learned infection control here, so I can prevent all my infections in my hospitals. Definitely no. Already we are least earning, so we need a little bit more infections to survive also there. Straight away begin with the case here there. So this is a 28-year-old male. This is a real case study. I have not cooked up here anything. He's basically an engineering guy, recently engaged. Sorry, I didn't do anything. I think the slides are gone. Yeah. So this person is getting married in November 2025. He was traveling to US in February 2025. That point of time for US visa, he got a HIV test as per the company rules. He did, that was negative. Then before engagement in July 2025 is engagement, June 2025 and root canal treatment there. August 2025 again to Hong Kong or Taiwan, I do not know. Again did for HIV test that came back positive. Strongly denies no exposures. We took him personally and asked him any exposures. He said no. So what are we going to do now? How many say yes, this is my root canal only caused the HIV to him? Nobody want to take the claim? No? Okay. No, my sterilization is damn good. We follow all sterilization practices, what is written in the book. Who is the dentist? You want to know that? Okay. Check any bachelor party he created then after the engagement or something there. First stop the marriage. Marriage is happening in November. This is a big dilemma we are facing now. So whether the root canal is a cause for the HIV transmissions or not, that's a big problem there. So this is a case like we are encountering and we try to solve the problem now. So I asked like a lot of questions, you are asking a lot of QR code. I didn't give the QR code for this one. Who is most dangerous? You are dangerous to your patient. How many say I am dangerous to my patient? Nobody? My patient is dangerous to me there. They start hitting also. A lot of people got hits there. So my patient is patient transmitting thing there. Who is dangerous to you there? So you are saying your patient is dangerous. You are getting a lot of infections. Particularly now flu season is started. So your people are coming and we can't ask the patient to put a mask and come and sit in front of you there. That's other big problem. Most of the patient side, we put the mask, the patients come in. So this is a big challenge for you. But according to the data, patient is transmitting. If you see the width of the arrow, the width of the arrow, patient to the dentist is more. Not necessarily this is HIV hepatitis B. Yes, HIV hepatitis B is also possible. But apart from the HIV hepatitis B, you are getting a lot more infections like flu, corona, everybody knows it. Flu, corona, all respiratory syncytial viruses, you are going to get it right now. Yeah, you are also going to transmit, not you. If you fail to follow certain infection control practices in your office, that's a problem now. And your patient also can transmit provided you got a big number of patients waiting in your office, they are going to transmit. Not like other settings. For example, we practices in IP settings where a lot of patients got colonized with one resistant bacteria, they will transmit other bacteria. That's also possible. So my objective is why you need to know the infection control. That's most important thing. I'm going to touch upon the basics of sterilizations and disinfections. I can't teach the entire lessons today. And why antibiotic stewardship? Antibiotic stewardship, other major area. What is the problem also, I'll tell it. How to choose antibiotics in your practice, I'll simplify. And couple more things. You got needle stick injuries, what are you going to do? What are the mucosal exposures you're going to do, and I'll try to summarize at the end. This is my basic idea I'm going to do in next 20-25 minutes there, so that whatever questions you're going to shoot up, I can answer the thing. So the potential route, I put DHCP. DHCP means dental healthcare practices. I not put dental healthcare professional. This is dental healthcare practice setting. From dental healthcare practice setting, the patient may get some infections. From patient also, that again the arrow, if you see, patient to the dental healthcare professional is more, and patient to patient is not that great for me either in dental settings, but in real world setting it is more. So this is my basic idea. So what are you going to do? So why you need to know? Previous discussions happening. If you do not know anesthesia, if you do not know what agent to use, if you do not know CPR, you are going to be legal, you are going to face a lawsuit. But here, it's not only lawsuit, your practice is also be banned. This is one of the big Sydney center where almost 40,000 patients were between 2005 to 2008 because the instruments was not sterile. If you read the thing, the instruments was not sterile. A lot of HIV scare. Almost the services, the licenses were suspended. The licenses were suspended. Not only the lawsuit, they need going to pay the money. You are going to suspend your license also. Keep in mind, provided if you do not know the sterilizations, disinfections, this is going to happen. Particularly in the era of social media, this is more. One patient puts in a social media, your career will be spoiled there. So keep in mind. So that's why you need to learn why the disinfections and sterilizations. And second thing, as I told earlier, you are also going to get infections. One part is your practice. Second part is your health. The first purple or infections, dental infection is HIV from the patients, hepatitis B from the patients, hepatitis C from the patients. For example, hepatitis B at least we can prevent provided you have taken the vaccinations now. Hepatitis C, good treatment is available, but for HIV, yes, post-exposure prophylaxis, after the needle stick injury, after the mucosal exposures, you're going to protect. Otherwise, this is a proven cases as selected. Dental healthcare persons is not immune. That's the bottom line. So why you need to know infection control practices in your practice? One, your practice should go on. You should not face any legal problems with it. Third thing, your license should not be suspended. And fourth thing, your social media account should be safe. And fifth thing, you should not get any infection. That's the reason I'm talking today there. Okay, so what are the things? Both patients, and I told earlier, both patients and you are not safe. Contact with the blood, oral, respiratory secretions, all will transmit. Blood, oral secretions, respiratory secretions, and contaminated equipment, this plays a big role. Proper procedures, you can prevent it. That's more important for you. Okay, so coming back to this case, how many says, I want to check the processing area. We have not seen any dental processing unit areas. Most of the thing we go to the clinic, we are saying my sterilization is good. Where you're doing the sterilizations, I want to find out there. How many got dental processing unit areas in your clinic or in the hospitals there? You got a separate dedicated dental processing unit. But if you go to the hospital, we got a department called Central Sterilization Services Department, CSST we can call it. A lot of people are working on it, keep the things. But for a dental clinic, we usually don't see the thing. A lot of turnaround time, I do not know how you are managing. I thought of doing on QR code surveys, what you are having it, that we need to check it. So finding a dental processing unit is most difficult thing. Finding a guard is easy. Finding a dental processing unit or dental cleaning unit in a dental clinic is the most challenging for us there. That's a big problem, I'm facing it. So basics of sterilization, this is a basic of sterilizations. You need to know your enemy well. What is your enemy? Bacteria or microorganisms. If you see, these are all the microorganisms. Sorry for the small letters. Usually whether you are dealing with a bacteria, whether you are dealing with a virus, whether you are dealing with the spore forming organisms, or whether you are dealing with the prion. Prion is the most difficult thing. But bacteria is easy to kill. Whichever things is multiplying fast, we can kill it. Whichever things like we got a envelope is easy to kill, but which organisms lack envelope, very difficult to kill, and particularly TB bacilli, and if you got a spore forming bacilli is the most challenging for you. So we need to know, remember what I am dealing with it. Fortunately, you people are dealing most of the time with the vegetative bacteria, keep in mind. Second thing, we need to know what sort of instruments you are using it. What sort of instruments I'm using it. We ask three categories, it's called Spalding classification there. Whether the instruments go and touch the mucosal surfaces and crosses the blood or sterile area. For example, you are doing some procedure that invade the blood vessels, whether the area is a sterile, I'm entering the sterile area, that instruments, we need to remember. Second thing, when you're going to touch the mucosal surfaces, most of the instruments you're going to touch the mucosal surfaces, but without any bleeding. Without any bleeding. That is called category 2, mucosal surfaces. The third one is just skin contact only. For example, the X-ray machines where you're taking the person can go and stick to the chin alone there, where contact with the skin alone. That's not even mucosal surface. That is very less. So for that, we can wipe with some alcohol, swab or fine. That means low level disinfectant. If any instrument that goes inside the patient's sterile area, I need to do sterilization. So rightly point out, sterilization means best thing is autoclave. So sterilization is needed. That's most important, then keep in mind. So you need to know two things. What is your enemy? What I'm dealing with it? Fortunately, you are dealing with a vegetative bacteria. Second thing, we need to know whether sterilizations or disinfections. We need to think about it. Most of the people do disinfection, not sterilizations, because sterilization needs a little bit of setup there. Then third thing, what we need to know, this is a sterilization. What do you mean by sterilizations? It should kill all the things except prion. Most of the time, prion is most difficult to think. It will kill vegetative bacteria, envelope virus, non-envelope virus, TB bacilli, spores, all will knocked out by sterilization. But what do you mean by disinfections? Disinfections only Particularly, we divide the disinfectant into 3 levels: high level, mid level, and we are giving it into low level disinfectants. High level disinfectants, except spore forming, all other things is taken care. Spore forming bacilli is very rarely encountered by dental practice, so we can take care at least high level disinfectant. That's most important thing. So this is a classification. If it is a sterilization, it will knock out everything. High level disinfection, spores may not, but most of the time it will take care of the vegetative bacteria, envelope virus, non-envelope virus, TB bacilli. Keep in mind, this is the most important thing in your practice. This is the basics. Unless you know these basics, it's very difficult to plan your setting, what level of disinfections you're going to plan. That's most difficult for you. So keep in mind these things that's required. And third thing is autoclave. People say autoclave. Autoclave means usually what happens, we put some water, we boil the water, it creates like a pressure, the steam is coming out. Steam has got excellent penetration into the instrument. It sucks also, it creates more steam and go penetrations and kill the organisms. But what temperature I need to come back, I'll show what temperature we need to maintain. This is most of the steam, either vertical one or horizontal one, but you need to keep certain monitors. That's called class indicators, chemical indicators or biological indicators. Whether my sterilization is clean or not, we need to check. That indicator we need to keep in the practice. That's most important thing. The below one I'm showing is a chemical indicator. There are two types of chemical indicators. What are all the indicators? People say you got sterilization, disinfections. What chemical indicator are you using? There are class 1 to class 6 chemical indicators. Which class you are using? Anyone? We can give some real prices there. So people answer autoclave, you can get up and answer now, we get the price. What indicator are you using it there? Guess, crude guess. So what we do is the class 1 indicator is placed on the outside. This is called the class 1. It is placed in the tray what you are sending into the autoclave. That indicate that tray is just passed into the sterilizer and came out of the sterilizer. That's it. So when before passing into the sterilizer, the color will be different. Once it come out of the sterilizer, it will say color is different. It won't say the instrument is sterile or not. It's called class 1 indicator to check whether the instrument gone through the sterilizations or not. What we keep inside the tray is called the class 5 indicator, because most of the people, doctor is saying about the spores, very difficult to use a microbiological or biological indicator. What we are using is a class 5 indicator. Class 5 indicator should place inside the tray. The color will change mean the instrument is sterile. Such a simple thing you can do. So you need to use a two type of indicator. One is called class 1, whether the instrument passed through the sterilizer or not. The class 5 indicator, once you start opening the tray, see the class indicator placed or not. If the indicator is passed through, that's called class 5 indicator. That's a crude way of assessing whether the instrument is good or not. What is the best method is biological indicator. But biological indicator is costly. Previously, I need to wait for 48 hours. I need to keep the biological indicator in the tray, then keep it out of it, wait for 48 hours, incubate, check any growth happening or not. But nowadays, we are getting a rapid biological indicator within turnaround time of 2 to 3 hours. I don't think so. Most of the dental practices can wait to 2 to 3 hours. But if you got a time, you can do the biological sterilizations one day before and keep using the biological indicator. That's good. Biological indicators are slightly costly. So we need to know the indicators also, whether my sterilization is good or not. That's we need to know. So this is the sterilizations. All critical items, ideal sterilization. All critical items, anything that goes through the sterile area, anything that goes through the blood vessels, do sterilization is the best method of killing all the organisms. If it's coming to the semi-critical area, use an high-level disinfectant. High-level disinfectant, that's more important for you. So you decide whether it's going to touch the skin of the patients, whether the instrument go to the mucosal surface, whether the instrument go to the sterile area. Based upon the thing, decide what is you're going to do the practice. And we need to know the temperatures. I think the temperatures, I kept it. This is a biological indicator, we are talking about it. Very difficult, 48 hours time, but nowadays rapid biological indicators come up. And if you want to cut down the durations of your time, these are all the things need sterilizations. Whatever scalpel bladels, periodontal scalers, surgical burrs, we need to use a sterilization. No excuses. Please go for sterilization. And we need to know the temperature. Suppose if you want to cut down the temperatures, if you are going to keep 134 degrees Celsius, you can cut down the duration of the cycle 3 minutes. But again, the 3 minutes is an exposure time. After the exposure, it need to cool down. It will take time. So don't say within 3 minutes I can finish my sterilization there. 3 minutes is the exposure time. Previous set, we need to clean the instrument, pack the instrument, put it in the sterilizer. If you use 134 degrees, 3 minutes is fine. But standard is 121. 121 means I need the exposure of 15 minutes, I need to keep it. If it is 134, you can keep 3 minutes. But again, somebody should wash the instrument, clean the instrument, pack the instrument, put the indicator, load it into sterilizer. This is more important for you. So this is what we need. This is called, sorry, wood unfortunately. So these are all the agents we use for high level disinfectant. So the common nuisance is nobody is using formaldehyde. Formaldehyde is carcinogenic. Whether you are going to give the infections or not, you are going to get cancer if you start using formaldehyde. That's why the fumigations and other things is gone now. So formaldehyde is carcinogenic. What we are using is previously glutaraldehyde. Nowadays we are using orthotaldehyde. The advantages, the killing efficacy is much better, but spores is not that comfortable. It can kill bacteria, vegetable bacteria, vegetative bacteria and viruses, both enveloped and non-enveloped TB bacilli, but the chances of killing spores is a bit difficult. We need to dip the instrument in appropriate concentrations for appropriate time. That's more important. That's called orthotaldehyde. Nowadays people are using parasitic acid. Again, it's good for dental instruments. Most of the dental instruments is good. When you are not able to do the sterilizations, this is a step, this is alternate to your good sterilization practices, but always sterilizations for a critical items, keep in mind. That's more important for you. So what are the things? Dental mirrors, whatever your amalgam condensers and dental hand pieces, you need to do that with the help of high level disinfectant. Don't use low level disinfectant. Even medium level disinfectant, I'm not encouraging. Use a high level disinfectant, what is available to you, that's the best thing. Otherwise your patient is getting infection. Once your patient is getting infections, you are going to get a lawsuit. That's the problem there. So, for example, the people's using water, the dental water. If the dental water is not tested properly, this will happen. One is called non-TB mycobacteria. People keep on getting sinuses from the procedures what you did. Keep on, the cervicofacial sinuses keep happening. This is not TB. This is non-TB mycobacteria because of the water is not clean. For example, following a laparoscopic surgery, following LSCS surgeries, following CABG surgeries, people keep on getting infections, the wound is not healing. That is basically because the water is not good. What happens, the surgeon usually put the laparoscope or whatever instrument, dental instrument in the orthotaldehyde or glutaraldehyde or parasitic acid. You are dipping in for 15 minutes, 20 minutes. After that, what you do? You take out of the instruments. You need to flush the instruments with either alcohol, ethanol, or you need to flush the instruments with sterile water. But what your technicians or what your assistants will do, take the instruments after the parasitic acid or orthotaldehyde, go to the tap water, flush with the tap water. The tap water contains non-TB mycobacteria. So the list, one of the major outbreak happened in one of the public sector hospitals. Following arthroscopy, all arthroscopy got infected. Every second month they're getting infections, multiple pusses, multiple discharges keep happening. I went and audited for 2 hours. Everything perfect. Everything perfect. I saw the person is doing well. They perfectly cleaned it, perfectly washed it, put it in the orthotaldehyde for 15 to 20 minutes. I said everything going well, so something is going on. So I just want to leave that. That point of time, I checked the person, took the instruments, went to the tap, put the tap water inside and came out. So this is a reason for it. So tap water is a culprit. Even dental water is a culprit. We need to check the colony forming unit of a dental water. It should be less than 500 colony forming units. Usually we keep 200 colony forming units. For you people, you are VIP, we are giving 500 colony forming units there. So we need to keep 500 colony forming unit. Similarly, what are the areas? For example, the person is occupied, some blood spills happen. How to clean? For blood spills and other thing, you can use quaternary ammonium compounds. You can use the surface area cleaning. Similarly, the dental chairs, after the procedure is over, we need to wipe, we need to clean. Otherwise, patient to patient cross infections. MRSA patients colonize, KB's patients come and sit your table, next patient is going to get it. How patient is going to get? This is the way they're going to get it. So clean the surface, that's most important thing. Clean the surface, that's most important thing. So use either medium level disinfectant is fine for cleaning the surfaces. Even good soap and water is good. For government hospitals, even ordinary phenolic compounds is also good for cleaning the surfaces, not the instrument. So we need to know what are all the instruments and what are the things we need to use for it. Whether the instrument goes inside the clean area, whether the instrument's going into the mucosal area, keep in mind. If you know these things, it's easy for you to tackle it there. So housekeeping, soap, water or EP agents, clean mops and clothes is required. Prepare cleaning and disinfection is more important. Wipe the surfaces. Whatever surfaces the persons come in contact, wipe it. Otherwise, you are going to get infections right now. So how to handle the waste? Most of the time, you need to have a tie-up with some terminal disposer. For example, GJ Multiclave or Ramki or something, you need to have proper policies and expose. Usually what they do in hospitals, we autoclave the medical waste, then give it to that terminal person. But in a small clinics, very difficult for using one autoclave for instrument cleaning and one autoclave for destructions is very difficult. So what we need to do, at least in the biohazard bag, put it in a biohazard bag. Whatever teeth you are removing, whatever soft tissue you are removing, please put it in a biohazard bag, not in a green or black. That's a standard bag, don't use it. Biohazard bag, put it and hand it over properly. So these things is required, otherwise Environmental Pollution Control Board can put some notices, legal notices can serve to you there. How to handle the waste, that's most important thing. You can't take the waste as a easy one. So what is the dental unit water? I already told you need to have 500 colony forming, periodic checkup needed. You need to have some RO plant inside to check the quality of water what you are using it. Otherwise non-TB mycobacteria can come to the patients, and a lot of other loose stools and diarrhea can also happen to the patients. This is why we need to have dental water line is also very important. Unless you keep these things, always keep prepared for legal lawsuits any point of time there. Now it's more important. You need to be professional, otherwise there is no differences between this guy and you. This guy can do a wonderful fitting their teeth there. He can put proper teeth, but this person does not know what is sterilizations, what is disinfections. So we need to know sterilization, disinfections. Unless we need to know, it's a bit difficult. That is why we are discussing about it right now. Okay. So my second part now, I'm switching out to antibiotics. So sterilization means you need to know the bacteria, what we are dealing with it, what instrument. Ideal thing is autoclave. If autoclave is not tolerable, plasma sterilization is other method. 40 minutes you can do. That's called hydrogen peroxide. Or ETO is a bit difficult for a small clinic. Hydrogen peroxide is good. Or autoclave, if you are able to get it, autoclave is good. And similarly, take care of the water, take care of the surfaces, take care of you also there. Then the second thing is antibiotic stewardship. What antibiotic prophylaxis? How many says, I want a physician clearance? I am not choosing my antibiotics. Nobody? You are choosing your antibiotics. Give antibiotics for 3 days and plan RCT. Just caries teeth, nothing. Pregnancy, okay. Do RCT today and give antibiotics. After the procedure, I'll give it antibiotics. Do RCT without antibiotics. How many people without antibiotics are doing procedures? Okay. Lot of whom only is there. Okay. Fine. So why this antibiotic procedure? This is one recent paper there. So if the private practitioners, that's why the session is also arranged, and you want to specifically talk about the antibiotics. Dr. Raghu was essentially asking talk about the antibiotic practices. What happened? For example, the 265 prescriptions done, out of 265 prescriptions, 4% of antibiotic choices is correct. What antibiotic you selected, only 4% of occasion is correct. Out of 265, 261 time, your antibiotic choice is not correct. What happened? The impact. People are using 7 to 10 days. If you see, 3 days is very hardly using there. Most of the people are using 7 days, or people are using 10 days also. I'll come back this part, how long to use the antibiotic, my last part of my slides. So this is what, suppose you got some training program today and you are enrolled there, the duration is cut down, So training gives a lot of education to you. Education gives a lot of good practices for you people. These are all practical advices, you can follow it up there. So that's why the session is there. The objective is to cut down the antibiotics, unnecessary antibiotics. I'll come back and explain. This is one of the paper written by one of the Savita College dental faculty in Lancet. We need to have some good antibiotic stewardship practices for dental people. This is written in 2024 Lancet. So this is what she has written there. So why antibiotic? So this is the first case of antibiotics in 1942. This is not now. This is 1942. Bad dental infections or odontogenic infection, the child has got it. So what happened? If the child comes to you today, what will you do? Debride. Unless you debride, it's very difficult. They tried all interventions. Unfortunately, the child was not improving. But penicillin came into the market at that point of time. With penicillin, the child became queen of the hospitals. She lived up to the age of 2008 or 2010. This is happened in 1940, up to the age of 85 to 88. Gave a famous interview at the age of 82. Penicillin saved my life for 8 years. Penicillin is a real magic bullet that saved the life of this child. From 1942 to 2012, she lived up to the age of 80 there. So this is the impact of antibiotics in 1940. Unfortunately, I'm not seeing this impact nowadays. Unless my surgeon debrides, I can't treat the antibiotic. There is no good antibiotic to me there. That's the problem. Why? The end of antibiotics. Almost all the antibiotics are dead, resistant. Bacteria is most intelligent creature. Don't underestimate your enemy. We think bacteria, why? Bacteria is the most intelligent creatures. We can't treat the bacteria with whatever available antibiotics right now. Whatever good implantations, whatever good implants you are putting, the person has got infected, it's the end of the story for you there. So you did a good procedures, but unfortunately the person got infections. There is no antibiotic to treat the infection. That's the problem we are having it. And you see who was the culprit? Dentists use a lot of antibiotics. Dentists use a lot of antibiotics. You are the leaders. 1 in 10 antibiotics you are prescribing there. That's a problem. And you are the third or fourth highest prescriber. The first couple of people are physicians, family medicine people. Number 3 is a dentist. You are prescribing more antibiotic. That's why we need to know how to choose the antibiotic. Unless we need to know the antibiotics, it's a bit difficult for you people to understand what is going on. That's the problem now. So coming back to this case, what antibiotic are going to give now? So already people are stuck. We divide the indications into 3 or 4. First thing is called prophylaxis. I need to give antibiotic to prevent some infections. Very few indications need prophylaxis, particularly when I'll show when to give the prophylaxis 1. Second thing is a treatment. Second thing is a treatment. In the treatment, when you got the culture and the culture is positive, that is called definite treatment. When you send the cultures or when you're not able to send the culture, that's called empirical therapy. So one is prophylaxis, other is definite treatment, third is a empirical therapy. We need to know these things before you choose antibiotics. And this is one of the cases for the antibiotics consensus for the dental patient. This is a beautiful references for you. It clearly shows for prophylaxis, most of the time, this is British Society of Antimicrobial Chemotherapy. Most of the antibiotic, people always say infective endocarditis. If I don't give antibiotics, the person developing infective endocarditis. Infective endocarditis will not happen. Even brushing the teeth, normal brushing the teeth, 30% of occasions bacteremia can happen. Bacteria, if you brush their teeth, what will happen? 30% of the time, bacteria can go into the blood. If the person has got some abnormal valve, that can go and seed the valve. That's more important. So 30% of occasions, brushing their teeth itself is a risk. So don't consider when to give antibiotic prophylaxis to prevent infective endocarditis. If the person has got previous IE, infective endocarditis, yes. The person has got a prosthetic cardiac valve, not prosthetic joint, prosthetic cardiac valve. Surgical shunts, congenital heart disease, you need to give prophylaxis. Or your procedures requiring involving dentogingival manipulations, you want to do the gingival manipulation, yes. That point of time you need to give prophylaxis, otherwise don't give prophylaxis. And if what prophylaxis, amoxicillin is fine or amoxicillin clavulanic acid is fine. People put, we have seen the prescriptions, amoxiclav along with metronidazole. What is the role of metronidazole? Amoxiclav has got a good anaerobic cover. When we saw the metronidazole along with amoxiclav prescriptions, we'll offer to you people there. You do not know the spectrum. Antibiotic choice depends upon the spectrum. Amoxiclav will cover streptococci, staphylococci, oral anaerobes. There is no need for any specific metronidazole for a oral procedures because amoxiclav will take care. What the dose? 1 dose before procedure. That's fine. If you think about it, only 1 dose. But people are giving 3 to 5 days before procedure, after procedure 10 days. What it causes? Loose stools, anaphylaxis. Then you need to have anesthetist in your OP, in your settings to give some sedations and everything there. So think about it. Don't give unnecessary antibiotics. Suppose the person has got real allergy. Most of the time the patients say, I got penicillin allergy. I asked the history when the penicillin allergy 40 years back. What happened? Mild itching or loose stools. So elicit a proper history. If the history does not suggestive of anaphylaxis, give amoxicillin. In fact, penicillin allergy patients, we can check with amoxicillin, or clindamycin is fine, or cephalexin is also fine. So we can try that one. So this is what we need to know, whether the patient has got prosthetic valve, prosthetic material used to repair, history of previous infective endocarditis, unrepaired congenital heart disease. Patient has got repaired congenital but residual lesion is still present, heart transplant patients. They need infective endocarditis prophylaxis, apart from your gingival manipulations. So whether procedure related or underlying heart diseases, these heart diseases only need. What are the things does not require prophylaxis? Prosthetic joint. Patient has got prosthetic joint, no need for prophylaxis. Active or recovered prosthetic joint, no. Extensive procedures, no. What antibiotic? Amoxicillin 2 grams. If you think the pediatric are handling 50 mg per kg is fine. So this is a prophylaxis, you need to give it. If the person has got allergy, you can use clindamycin. That's the best thing, but prove the allergy. That is most important thing for you. Suppose you say prosthetic joint, I'm really worried about it. If the prosthetic joint happen, immunocompromised patients in addition to the prosthetic joint, and the joint is a new one, less than 1 year. Yes. Otherwise, if the joint is more than 1 year, there's no need for prophylaxis. Worst scenario, I don't want to think these things. 1 dose of antibiotic you are giving legally are protected. 1 dose before 2 hours. Suppose you are giving orally 2 hours before the procedures. If you are giving IV 1 hour before procedure is fine. At least 1 dose of antibiotic. That's it. You don't bother about whether the person is previously joined, 1 year, immunocompromised, nothing. I want to give prophylaxis, 1 dose is fine. Take home. That's the message for you. Coming back to this child, what will happen? She has got a severe, now not 1942, this is 2025. I can't use penicillin. Nobody is using penicillin nowadays to treat the infections, and penicillin is also not responding. What antibiotic are going to give for this child? Any takers? How many say amoxicillin? Nowadays, people don't want to put amoxicillin metro from here. That's a take-home message today there. So, clindamycin, ciprofloxacin, levofloxacin. So, we need to know the antibiotic. The antibiotic choice depends upon 3 factors. 1, what sort of host I am dealing with it. The person is a poorly controlled diabetic, lot of comorbid, previous drug allergy, this sort of host I'm dealing with it or not. Second thing, where is the infections? This patient has got a bad odontogenic infections, I know. Second thing I need to know. Third thing, what drug I'm going to use? What drug I'm going to use for the patients? So these things, if you remember, that's fine. So we need to know where is the infections. We always ask to write two things. Where is the infections? So what drug you are going to use it? What sort of host you are dealing with it? Keep in mind, where is the infections? What sort of host I am doing with it? Whether it's a odontogenic, whether it's a pulp, whether it's a periodontal, or whether it's an infected cyst or remaining roots. So you need to think about it. Where is the infections? Depending upon the infections only, your antibiotic choice will go away. So odontogenic infections, there are 300 to 700 species of the bacteria. This is your enemy. But most of the things, this is aerobic plus or minus anaerobic organisms. You need to provide some good anaerobic because it's oral cavity. So you need to provide gram positive along with anaerobes. There's no need for major gram negative agents. For that, we need to know what antibiotic has got gram positive, what antibiotic is gram negative, what are all anaerobic cover. Can you tell 5 antibiotics that has got anaerobic cover apart from amoxicillin? Amoxicillin, metronidazole, clindamycin, your piperacillin, tazobactam, meropenem, all has got good anaerobic cover. So need to think about it. So anaerobic cover is very important. So this is a therapy, they keep on saying penicillin. This is a Western guidelines. In India, I can't use a penicillin because the penicillin resistance is so much. And similarly, we can try clindamycin fine. We can try amoxicillin, that's also fine. I'll show in a minute. So another case, this is a polytrauma, orthofacial surgeon. Polytrauma, a lot of trauma has happened to the persons. What antibiotic will use for this one? Bad trauma, received some antibiotic in government setup, shifted to the private care. What will you do? Any takers? How to choose your antibiotics? So this is called the spectrum. For example, if I use meropenem, what are all the bacteria meropenem covers? Meropenem cover gram negative, E. coli, Klebsiella, Pseudomonas. Gram positive, Staphylococcus, Streptococci. But MRSA it won't cover. VRE it won't cover. Similarly, you are using piperacillin, tazobactam. What the agents it covers? This is called the spectrum. Unfortunately, was not taught in your pharmacology. That's the problem we are facing. For example, ciprofloxacin, levofloxacin, moxifloxacin, all are fluoroquinolone. Cipro has got no cover for streptococci. Cipro is good for Pseudomonas. Cipro is good for E. coli. But levofloxacin both gram positive, gram negative. Moxifloxacin no gram negative. So ampicillin, amoxicillin don't penetrate the brain. Ampicillin will penetrate the brain. So we need to know the differences between the group. What is the bacteria it covers? For example, if I think streptococci or staphylococci, you can use penicillin, you can use first generation cephalosporin, second generation cephalosporin, you can use amoxicillin or you can use amoxicillin clavulanic acid. That will take care. The third thing is whether the particular antibiotic. In microbiology lab, what they do, they take 10 to the power of 5 organisms, they put a fixed concentration so the drug check whether it's working or not. But what happened in real life? For example, the concentrations of the antibiotic may be low or the concentrations, for example, urinary tract, the concentrations of antibiotic is very high. Even though the bacteria is less, even though it is resistant, sometimes will work. That is called in vivo, in vitro mismatch. So we need to know whether the antibiotic will reach particular site or not. For example, if you got infections in the soft tissue, whether the antibiotic will go and reach the soft tissue, whether the antibiotic penetrate your maxilla or mandible bone or not, that is more important. Penetrations. Clindamycin has got excellent penetrations. Amoxicillin 60 to 70%. So if you think the person has got some mandibular osteitis or maxillary osteomyelitis, use a good penetrating drug. That is more important for you. It should penetrate the bone. And second thing, it should be available orally and it should not have resistance to the thing. That's the problem. And people are using underdosing. For example, people are using 625 BD. Usually, if you want to use mg per kg, that's more important. If you want to use ciprofloxacin, 750 milligram BD. If you want to use amoxicillin clavulanic acid, either 1 gram BD as a oral therapy or 625 TDS. So know the maximum dose. Don't underdose it. Use the maximum dose. Maximum dose is most important. People say, I can't tolerate. Doctor is giving very high dose. Very toxic doses they're giving. No. We need to use a maximum dose. That's most important thing. And we need to know the durations. The duration is most important thing. Now there are two concepts is emerging in antibiotics. Bacteria does not know how the antibiotic reaches the bacteria. Whether it's given IV, oral, bacteria has got no clue. How the antibiotic reaches the bacteria does not know. If the oral antibiotic is good, this man is called the Brad Spellberg. He is demonstrating RCT, randomized control trial, to show whether oral is equal to IV or oral is superior to IV. He has shown multiple RCT, oral is equal to IV. So don't say I want to give IV amoxicillin. Oral amoxicillin is good. There are no RCT proven IV amoxicillin is superior. Similarly, if the oral antibiotic is there, for example, piperacillin tazobactam, bad multi-trauma or polytrauma you're handling with orofacial maxillary infections, oral is equal to IV. And most important thing, this is most important thing, short is sweet. Prophylaxis means only one dose. If the infection is source control, you did the drainage, treat shorter. Do not irritate the bacteria. I told earlier, bacteria is the most intelligent creatures. If you start irritating, it produces a resistance. It produces a resistance, it will not act. So this is a problem. So do not irritate. For pneumonia itself, I am treating 3 days. So you think about it. Except few infections like osteomyelitis, septic arthritis, these type of things, yes, you can treat longer. Otherwise, if the source control happens, short is sweet. Do not irritate. All are RCT, randomized control trial evidence. I'm showing the evidence without any evidence, I'm not talking. So this is a mantra for you. So short is sweet, oral is equal to IV. Know the bacteria, know the spectrum, choose your antibiotics. Don't do a guesswork, learn it. Most important. I not told 1945 Alexander Fleming, when he was receiving a Nobel Prize for his penicillin invention, he told the 3 things. Whether I want to use antibiotic or not, first questions. Not for every dental procedures antibiotic is needed. If you are doing some gingival manipulation, yes. The person has got underlying heart diseases, yes, you can do. Not routine heart diseases, infective endocarditis, prosthetic valve, congenital disease, yes, you can give prophylaxis. If you want to dose, do the maximum dose, minimum durations. He told in 1945, now the Brad Spielberg is working for this one for the last 15, 20 years, he's working on it to find out the truth what is told in the 1945. Indicated use, maximum dose, minimum durations. This is a mantra for antibiotic resistance. Otherwise, your name also will be there. You are the top 10 people created more antibiotic resistance in the community there. You need to keep them in the mind. So my last part of my talk is, this is for you. The person is injecting a local anesthesia, needle stick injury. What will you do? Take ART immediately. Take HIV, hepatitis B levels, wash the wound and proceed for the extraction. You're given a local anesthesia, it will work shortly. So before that, you want to finish the procedure there. Tell your husband no sex for next 4 weeks. So people wondering there. So don't worry about these things there. So we need to know that needle stick injury can transmit the infections 1 in 300 occasions, but which occasions I do not know. But if you take proper precautions, we can prevent it there. So we always do whether the person is positive or negative. Positive person needle stick injury risk is very high. But the source is not known, very difficult. But what we need to do, use glove. Without glove, don't do procedures. Think the person is looking good, no. We can't assume anybody, so put the glove, wash the hands is most important for you. Gives 1 tablet. Only 1 tablet is fine. I think I'm running out of time there. Hepatitis B, take the vaccines, demonstrate it. Demonstrate your titers more than 10 international units, you are protected lifelong. So take hepatitis B or check the hepatitis B titers. Prevention is always a primary. So don't go with unnecessary thing. Prevention is always primary. Wash the wound. That's most important thing. So people are worried about the careers and everything there. People say don't try anesthesia, trying nitrous oxide course and everything there. Is there any good course available? I want to switch my career. Yes. Infection control and infection prevention, quality control is a big job is coming up there. So those who are really interested, you need to take the course, infection control, how to set up an infection control for a hospital, not for dental practices. You can select an infection control setup in your practice, how to do that. Quality control, that's good thing there. So you can do a quality control, infection control settings. Yes, I want to switch my gears. Yes, you can. This is the time you can switch my gears. Not people with MDS, people with BDS, you can do the thing there. So we are coming with the infection prevention certificate course. This is an online course, 1 year coming up there. And we are checking your prescriptions, whether my antibiotic choice is correct or not. Also, something is coming up shortly. In October, we are launching it there. So we are saying my prescription is correct or not. No need to cross-check with other people. You can yourself can check with the thing. We are coming up now. So these are all the possibility. Those who are real innovator, this is the last day. We are extending 1 more day tomorrow. So I want to solve some real infection-related challenges. You can find out the problem in your practice also. This is hackathon, we can call it. We give the problem, provide a solution to me there. I am very extraordinary thinking persons. Just register. We can provide some engineering guy for your support and some management guy in the team. So you can form a team and solve. This is happening 25th and 26th of this month. Actually, today is the last date, but for this meeting, I asked the organizers to give 1 more day. So till tomorrow you can register for the thing. The problem statement will be given to you. You need to provide a solution to us. For example, how to set up a infection control practices in dental clinic. I said I've not seen any dental processing unit, so you need to come up with the thing. Come up with the problem in your practice, tell the solution to us, and we can support you. Once you show us good solutions, we can support you in monetary wise also there. So these are all the careers I'm supporting for you. Thanks for the wonderful opportunity. I'll take a couple of questions there.